Okay, let's get started. Thanks everyone for joining us today. My name is Caitlin Roberts and I'm the marketing lead here at Team Medical. Firstly, in the spirit of reconciliation, we'd like to acknowledge the traditional custodians of country throughout Australia and their connections to land, sea, and community. We pay our respect to the elders past and present and extend that respect to all Aboriginal and Torres Strait Islander peoples today. At Team Medical, we believe wound care is more than just products. It's about education, awareness, and empowering healthcare professionals like you who make a difference every single day. We'd like to extend a big thank you to Smith and Nephew for making today's education opportunity possible. We're pleased to have Agatha from Smith and Nephew joining us online today. Before we get into the presentation, we just have a few quick housekeeping items. Firstly, to limit disruptions, cameras and mics are turned off for all of our participants today, but you're welcome to ask questions and participate via the chat. We will gather those questions and we'll have a Q&A section at the end of the webinar where we will try and answer as many questions as possible. This session is being recorded and a link will be emailed to you tomorrow and will also be available on our events page. Before you head off, we'd love it if you can take a moment to complete a short survey. We really value your feedback. It helps us deliver what you'd like to hear about. Now, I'm pleased to introduce today's speaker, Associate Professor Jared Watts. Jared is a rural and remote obstetrician gynecologist. As a Director of Obstetrics and Gynecology for the WA Country Health Service, Jared is dedicated to improving maternal health care for First Nations women and rural communities. He also contributes to research at the Rural Clinic School of Western Australia. Over to you, Jared. Thank you for joining us today.
Great. Thank you so much. I was going to make sure you can hear and see me okay with one of you. Yeah, perfect. Okay. So look, thank you for the opportunity to speak to you today for about the next half an hour. We're going to speak about the dehisced Caesarean section wound and sort of a few little areas around that as well. So look, as you heard, I am a rural and remote obstetrician gynecologist. I have a bit of a research interest in Caesarean section wounds management. I don't have any relationship or interest in any companies and no payment or sponsorship for this presentation today, and all opinions are my own. So we have two aims today. So I'm going to first speak about ways you can sort of look at prevention, and definitely everything we speak about today. I'm going to speak about a little bit about, when we do the Caesarean sections and things like that, but really take a primary focus, noting that online today we have nurse practitioners, GPs that do all that primary healthcare so fantastically, and ways that we can work together. And then touch also on the management of patients who have had an infection, a wound breakdown, or dehiscence in the community. So I just want to also acknowledge the traditional owners of the land where I normally work. The Yaru people are in the northern Western Australia. So look, Caesarean sections are rising. We know this, and I could probably give another whole talk about if this is a good thing or a bad thing, but they are going up. And we can sort of see from the Australian Institute of Health and Welfare, sort of the data over the last sort of 20 years. And then unfortunately, sort of research shows that we do have about 3 to 15% of these Caesarean sections do become infected. And then if you actually have a look or think about it, our Caesarean section rates are going up and our rates of infection are about 3 to 15%, depending on a number of factors. This is a significant burden for mothers and families in society. Going back to this paper again, if you actually have a look at the risk factors for Caesarean section, we've got things like, these are the big ones, so obesity, smokers, diabetes and all types, or people have had previous abdominal surgery, whether that's a previous Caesarean section or other type of surgery, and definitely some medications that people are on, in particular anticoagulation therapy and steroids. And these ones are all going up also in society, or people that fall pregnant. So we really got the increased Caesarean section rate. We've still got quite a stable rate of Caesarean site infections, but we do have increasing risk factors, so we've got an increase in burden. So very much appreciate everyone's time today to speak about this issue. So why are we talking about infection? Because I do know the title is dehiscence, but we do find that surgical site infections quite often is the start of then things that go down to dehisce and wound breaks. So really in today's talk, I want to take it a step backwards to try and prevent the infections or identify them early so we stop the dehiscence and wound breakdown, but also what to do with those situations as well. So this is a huge issue for new mothers, and we can sort of see that there's a different aspect. So clinical, for example, that these mothers that have the dehiscence or wound breakdown, they need to have added appointments or come and see us more often in the hospital. There's the need for antibiotics, and we know there's short-term, long-term of those, and maybe some longer-term effects for the baby, but there's definitely, if mum's taken some antibiotics, they might have looser stools. There's the risk of needing readmission, IV antibiotics, or even going back to theatre, and financial costs, and particularly for the patient, but also for the health service as well, of having the infectional breakdown. And then I think for motherhood, and there's some really interesting research around this, but there's difficulties with bonding with their baby because they've got added appointments or they may be readmitted to hospital, difficulties with breastfeeding because of the pain, or maybe concerns that they don't want to breastfeed because of the antibiotics they're on or other medications. And it can be difficult to establish a routine. And I've literally this morning just given another talk on birth trauma. And it's incredible that, wound breakdown and things like this really is one of the factors that people have the sort of a traumatic birth experience. And this can lead to postnatal depression and post-traumatic stress disorder as well. So look, just taking it back to where I normally work day to day and how my interest in this area started is this is a document I'm sure in every state, probably every country, most countries of the world, we do get these reports come out. And this looks at the rates of cesarean sections back in my hospitals. And I sort of know which hospitals are mine. And you can sort of see that I had a little bit of a higher rate of cesarean section wound infections than other areas. So look, felt very guilty about this, and everyone was pointing fingers about the higher rates of infection. So we sort of started to do some research potentially into why this was happening. And so we sort of said, well, is this related to the surgeon? Is it one particular surgeon that's got the higher rates of infection, or one particular operating theatre? Because there's a few operating theatres in the hospitals. Is it maybe the midwife who takes the patient off you or the baby off you that's the reason, or the theatre team, or is it the equipment? So all these sort of things we actually had a look at to see if this was why we had a higher rate of cesarean sections. We took an audit, and it was actually a really detailed audit that we phoned every patient for 6 months that had a cesarean section in one of our hospitals, and looked through medical records and looked through the ED presentations, and just to sort of find out if we could really note what type of infections we had and what the percentages was. And when you actually ring up the patients, it's probably higher than the research, because some people might see their GP or nurse practitioners, and we sort of had that 41% of people were talking about some issue with their wound. And when we had a look at why, there wasn't really a factor. I couldn't just simply, fire one of the surgeons that was causing all of it. There didn't appear to be any relationship with any of these factors we talked about before. So we actually did have a look at why we have increased cesarean section rate infections. It was some other factors, such as people being from remote communities, if there was high blood loss during the cesarean section, if they were from a non-Caucasian background, if the cesarean section took longer than 46 minutes, if you had diabetes, definitely a risk factor. Our First Nations, not because of First Nations, but the potentially like institution racism and the factors that go with being a First Nations person that increase the rate of cesarean section, infections, and definitely is smokers as well. So then we sort of also had a look at a few factors such as antibiotics, which antibiotics we gave, and also when we gave those antibiotics compared to a cesarean section, and the type of dressings we used to see if these actually caused issues as well. And look, we did come down to so many of the factors that cause the increased rates of cesarean section are things we can't really change. They're the social determinants of health, such as people might come from a remote area, but just, when you do have a cesarean section, you're expected to get back on with life and looking after a new baby, and it's quite hard to look after the cesarean section wound as well. So what we did is we introduced a package aimed to reduce the bacterial load and management post-delivery to reduce the rates of infections. So this was from, changing the ways that we would offer people Chlorhex wash or showers when they came in, just for an induction or labour in case. We looked at the way that we prepped the skin, hair. We changed the way we gave antibiotics. We gave it sooner, related to the time of the cesarean section. Looked at MRSA screening, so the good old golden staph and things like that. We had a look at the way we could look at the dressings that we could place on, that they were ones that would provide better protection for infection. And we had a bit of a worksheet to try and decide which ones of these needed for which patients. So I was very excited after introducing this over a few months. We did once again call up all the patients and it was reduced to sort of down to 11.6%. So a significant reduction. And this is the publication if you want to go in to see some finer details about what the outcomes were. But I'll speak about them a little bit in detail now. So this is sort of just looking in the pre and post, and you will sort of see that, there's some big things that we did change, such as our dressings using Pico dressings, what we used in this study, but also addressing some of the other factors, such as when the antibiotics, hopefully to get a better outcome. So can we take this sort of into the primary care setting, which thankfully all you're much more aware of than I am, and sort of what we can actually do to try and also identify and these rates of cesarean infections, and also manage in quite early on if there is a suspected complication as well. So look, in prevention is coming down to risk factors. We do know, if you're a little bit more detailed, but BMI, we can sort of see that 1.6 to 3.7 increased rate. And because there's poor vascular supply, a pannus area that does cover the area of a cesarean section, surgical times is an independent factor for why we have breakdown of wounds. And we know that we probably need a higher dose of cefazolin, the antibiotic that most hospitals give before cesarean sections, in patients with an increased BMI. Then the diabetes as well, very high chance of being an issue because of all these factors, as well as the smoking, so 5 times the rate of infection and 9 of the wound breakdown. So look, what were some things, just going back to the prevention from the primary setting, once again, I'm sure you're all so much better aware of these than I am, but weight management, diabetes control, trying to quit smoking, review the medications going into a pregnancy, and also the review of your MRSA status and whether anything can be done. And that's the one that I sort of say, speak to your local team about what they feel can be done in your area to reduce that as well. And look, the thing then also in primary care is the education that, once again, this came up in the talk I gave this morning, that mums sort of say that, once they've had the baby, they're sleep deprived, they got so busy looking after this baby that quite often it's education early in the pregnancy about how, if you do end up with a cesarean section, or if you have a repeat cesarean section, how to look after your wound, what's the signs and symptoms to talk about, because quite often giving this information after deliveries, it's a bit harder to absorb. And also we'll talk about options available to try and prevent these later on. So look, now we're just going to talk about the dehisced caesarean section wound that I'm sure everyone has seen, and the steps that, that the evidence points towards, some things that I personally do just to try and manage them as well. So we talked about the same as, a dehisced caesarean section wound. We've talked about the clinical and the effects on motherhood, but there's also, scarring and people, that can be a lifelong, and also future pregnancies. If an infection does get lower, we know that there's complications with future caesarean sections as well, so quite important. So when we look at why, and this is why I've focused so much on infection, is why do we get dehisced caesarean section wounds? And it is because the vast majority do have an infection or increased exudate or sort of edema. And we, interestingly, 2 to 3-fold increased rates of caesarean section wound infections over a bowel resection. You sort of would think that would be a bigger operation, but it's because, these mums go on with life and looking after babies and moving around, whereas quite often after such bigger operations, people are laying in bed for quite a while. And I think this is why this is such an important area. So management, when does most of this actually occur? It is day 5 to 7 when they have been discharged from hospital and in the primary care setting. So you guys are the first on the ground to be able to identify when there are issues. And I think the first thing is to try and decide what type of dehiscence it is. So is this a full thickness, which is rarer, thankfully, but this is a clinical diagnosis. So some things that I've seen is you might have bulging skin because the sheath, so we're talking about the sheath is actually broken down, and you could even sometimes feel bowel contents under the skin or lots of exudate. So people have described putting sanitary pads on their wound because there's so much fluid coming out. Very rarely you can get a burst abdomen when you can actually see the bowel contents or something like that. It is a relatively urgent need for surgical review in these situations, no surprise. And you can, if you're still not sure, ultrasound can sort of help further diagnose it. But these are ones I think you'd be very easily able to forward back to the hospital for management. It's sort of the superficial ones that I feel that, management in the primary care setting to try and not disturb that child bonding and things like that is where we would, that your expertise would be greatly appreciated. So this is involving the skin, but the rectus remains closed or intact. So the way that I go through these is just to once again rule out sepsis, and I have seen quite severe sepsis just within the skin. And if this is the situation, refer as soon as you can, but also think about that 1 hour, that golden 1 hour to get in antibiotics, because sometimes these infections can be quite severe. So whether that's piperacillin or vancomycin or triples, I'd base that on your local guidelines as well. And then also just to rule out other causes of temperature. So make sure, sometimes we do focus just on the broken down wound, that we might realize there's a mastitis or there's rotaine crux in the uterus or endometritis or polyembolus or DVT, just to think about those things, because they all sometimes do come together as well. So look, once again, some of this stuff you probably know well and truly better than I do, but swabs plus urine and breast milk are really important to send out based on your clinical assessment. We do know that Staph aureus is about 40% of these cesarean section dehisced and breakdown in MRSA, very much depending on where you are, but potentially about 15% on average across Australia. And definitely I like to remind my registrars and things to make a slide, because you may be able to get more information quicker back than just putting it in the culture medium to send off straight away. Then I'd think about having a cesarean section if you need it. Is there a pocket or is there a deep infection that might need surgical drainage or undergo a guidance? So just have a think about that as well. Or if there's any suspected associated complications, such as that retained tissue, it's quite important to think about an ultrasound. So then moving on to antibiotics, I think that what I go through is the appearance of it. Does it look infected? Because quite often you do want to get on maybe before you get your swabs back. Think about your systemic features. Any risk factors, if it is a patient with increased BMI or diabetes, I'd have a lower threshold. And I think in general, we do have a lower threshold for using antibiotics, because the immune system definitely of a pregnant woman is different, and it's not traditionally saying suppressed, but it sort of acts a little bit suppressed, that sometimes infections can happen a lot quicker and there's a lot more exposed surfaces after that can become infected. But also, if you do hopefully get a discharge quite quickly from the hospital, have a look. Was there any surgical difficulties that maybe have increased the risk? Was it a long cesarean section? Was there a PPH? You might want to have a lower threshold to start antibiotics. The way that we normally go through is normal saline wash and dressings. If there's sort of no infections, just a dehiscence that you think that secondary granulation can help. But then if there is need, we sort of look at flucloxacillin, but if there's an allergy, depending on that, moving on to cefalexin or clindamycin, depending on it. And if you did have complications at the cesarean section, such as, or maybe a UTI in hospital, a lot of the guidelines talk about, amoxicillin clavulanic acid, or our trade name Augmentin, to use that sort of a little bit more first line if you think it's more than just skin flora, if there was sort of more difficulties with the cesarean section. The other things to think about is the suture and staples. And I think it depends on what day it is. So if it is that, you can remove the staples maybe a couple of days earlier, if it looks like they are a bit of an issue, sometimes releasing a staple or every second staple can actually have a bit of a discharge of any fluid or exudate or pus underneath of it. And just to have a think about the suture, quite often they're like continuous ones. It's a bit harder to remove, but what you might need to do, and always can get some advice. Wound packing is really good to if there's a lot of exudate or infection, but you sort of think you don't want to do too long, because it can make pockets that can be hard then to get that secondary healing, but it's very much an important thing that we have as well. And once again, I'm quite convinced you guys probably know more than I do, but in the primary setting about that. And then dressings, pain relief. It's really quite important to think about pain relief when you're doing dressings, and also that these women, pregnant people, now postnatal people, do have the activities of daily living, looking after, so they may need more pain relief because they're not able to lie around. Some of our big laparotomies or something like that. So to make sure that they're comfortable even with when there's an infection. And the back of your mind, think about DVT-PE prevention, as they are high risk from that being postnatal, and also adding the infection on as well. So with the dressings, this is a bit of a controversial area about exactly which one's the best, and I think it depends on where you are up into the healing process. But an absorbent dressing is one of the first line that we do use. So hydrocolloid dressings to assist with secondary intention. But what we actually had a look in some of our studies was that the negative pressure wound therapies were able to sort of give this like a primary healing, because they did pull the edges together, they kept the exudate away, and may prevent the need to sort of more go back to theatre for any closing, or actually close it over a little bit quicker. And we will talk about some other reasons that I found the negative pressure wound therapy were better. Can't spell there. But it's also things like you may not need to do as many wound dressings because of the ability that a lot of those devices have. A few things that are red flags that I've learned also from many years of dealing with this is, think about pain out of proportion. Only a few weeks ago, I did have a patient with, strep A, and strep A can progress so quickly, and the patient was in a lot more pain than it appeared. So just think about that and whether you need to refer them sooner rather than later. If anything's progressing quite quickly, that's another thing that it could be strep A or something underlying. So there might be a collection underneath the sheath that is just collecting under the skin. Also, I've learned, social stresses and stoic patients, mothers quite often put their babies first and don't want to, if they've got other children, it's hard with childcare. So people might downplay a little bit about how much the wound infection or dehiscence is causing it. And so just to take that in consideration. And then also, the afebrile unwell, I've seen a couple of cases of, once again, strep A, the thing that scares probably every doctor, midwife, obstetrician, nurse. But, you can be afebrile with strep A, but very unwell. And they often are people who have other children that are carrying of the strep A. So also just think about those other causes we did talk on that. I think they do come in packs, and you may just need to rule out, a connection some other way or area, or that you're not dealing with another cause of sepsis or secondary seeding. So ones to refer, full thickness dehiscence, I would suggest that sepsis, a connected defect, so maybe you have a connection or collection on an ultrasound in front of the uterus that then seems to go through the sheath under the subcutaneous. It might be best to refer those. A large pocket on ultrasound that you feel can't be drained. Retained products of conception because they can become infected quite easily. Failing to respond to the treatment or any rapidly progressing concern that you're worried about as well. So the other thing is just to back your head on, speaking to a group of nurse practitioners and GPs is very much your area that you should be teaching me about. But I do know that find that these patients, risk about postnatal depression. There's many issues with breastfeeding. So whether there's any way we can assist with, because they have failing to establish, because it might be painful to have the baby rest on that part of the body, then they can go on to develop mastitis or engorgement or pain because of issues with breastfeeding. And then just once again, that DVT-PE risk, unfortunately, it's such a high morbidity and mortality, unfortunately, in pregnant women of both those conditions in the first 6 weeks after delivery. So once again, then just looking at risk factors, so many of them we can't actually control. And so we do need to look at other ways that we can reduce these things. So this is negative pressure therapy. And sorry, I just went past a little bit too quick, but this is one of the things that we did introduce into our study to see if it made a bit of a difference as well. So how do they actually work? So there's quite a few different ways that they do things. So from the tension on both sides of the wound to sort of pull it together, there's a protection from contaminant. And I will talk about, I think you don't have to change the dressing as well. And if your patients do, might find that when they need to have a wound dressing, they may delay it because they've got to deal with breastfeeding and child. I find you can put sometimes these negative pressure dressings on and they can be left for longer. And so therefore you do get a bit more protection. And it also increases the lymphatic drainage, and it removes any hematomas or small hematomas or any exudate out into the device, which really all these things come together both for prevention and also for treatment afterwards. We found did make a bit of a difference. So a bit of a other picture, just sort of demonstrating some of those things from removing the fluid, pulling the surgical incision apart, and then the blood flow into the area to hopefully heal the process. And there is some studies that show that the granulation tissue actually goes quicker if you do have a negative pressure. So much that these devices are used in many areas of surgery now. So what are their uses? We do have sort of two big uses. So they are used prophylactically to prevent infection, and we'll talk about which patients we choose to use them in cesarean section and why it's very good for in a primary health setting to also know about them because of some TGA changes. And then also with minor dehiscences or even minor infections that they do have a role. It's not as studied as well because thankfully we don't have as many, compared to studies where you can look at them for the role of prevention. But I definitely think they make a difference. So with some evidence, I always like to look at evidence. This was the sort of the first big study came out of Denmark, Netherlands sort of region, looking at using negative pressure dressings after cesarean section to try and reduce that 15 to 3% rate. And there was use in women with increased BMI, and it did make quite a significant difference. So reduced, they had a slightly lower rate, I guess 9.2, which we do find in a lot of those Northern European countries, but it also reduced it to 4.6%. And this is the cost saving was incredible because the readmission rates, the need to go back to theatre for some cases, even unfortunately some of these cases can be so significant that patients have extended stays in hospital, HDU, ICU. So preventing those costs, it did come out with some cost savings as well. The other one is there's that exudate. So in the study, they found that there was less exudate, and this might actually, people may not need to change their dressings as often. And if there's too much exudate, this may include or can cause dehiscence further on. We then do have an Australian study that looked at the sort of the same things out of Griffith University that looked at increased BMI use, and we did sort of see a significant trend towards improvement in the subgroups of infection in all different types, and definitely the wound breakdown because of hematomas. So then there was, I think that it's not as like we did in my hospitals. We think that it's not just one thing, but you can put it in as a bit of a package. So this hospital here, like we did, started with Chlorhex preps, and then they use Pico dressings and vaginal cleansing, which is because when you do a cesarean section, you obviously open up that area, and then a different way of scrubbing the skin, and also had a reduction like we did with our multi-factor as well. And you can sort of see with each step, it did actually reduce the risk of infection. So looking at some national guidelines, we do have the NICE guideline that is recently updated that they do now recommend. And, the NICE guidelines look very much at cost as well as the clinical outcomes. So that for a BMI over 35, that, it can be used to reduce the risk of wound infections and the associated morbidity for women and motherhood and things like that as well. So we've got sort of the UK doing that. My level 4 evidence, I think I've touched on it throughout, level 4 being independent opinion. But I do find that when we use these sort of dressings in, we do have a lower threshold because of, I think we have a higher issues of social determinants of health. So with smokers, diabetes, and increased BMIs, we just found that it did make a big difference. And for so many reasons, so, people didn't want to have their dressings full of, an exudate or something like that. So they wanted to change it more often. I think, quite often just keeping the area as intact as possible for 48 hours is really important. If you do have one of these negative pressure, it allows to keep it as intact as long as possible, and people don't change the wound. So it's so many ways that these negative pressure dressings have actually improved for our patients. So I was going to talk about this, but we've actually got an expert to talk about. So this is just where the one that I use to talk about some background about Pico dressings as one form of it. So there are some risks that I will talk about. So you definitely need to have training or upskilling. So looking at some videos, and we'll have some, I believe there are some resources that are available because you do have a lower rate of failures, and nothing annoys patients more than the failure beeps that when the vacuum does break. So it is really important to put it on correctly so it can get the full benefit of it. There is a cost associated with it, and you need to choose the right patient. So it is cost effective as as well, rather just be able to place it on everyone. And the Australian study did show a slightly increased risk of blistering of the skin over traditional dressings. So just to take that in consideration, maybe warn patients if they do have those signs that they get it reviewed. So the reason, I think this is also very important is the TGA has approved direct-to-patient advertising. I did a quick look at TikTok, not that I know how to use it that well, but it is all over these negative dressings. And patients have now definitely come in and asked me, like, if I need a cesarean section, what's the evidence for and against this? So as primary health experts, there's a good chance that patients will be able to ask you and sort of give them some advice about what they should be using. And so we definitely have some expanding evidence also around the dehisced. I think the evidence is quite good there for prevention and dehisced wounds. There is a Lancet study as well looking at all types of dehisced wounds, not just cesarean section, that does point us that these do make a big difference and potentially reduce the time to follow up, the need for surgical intervention and wound closing as well. So with my 1 minute left, just a little bit of a summary of what sort of I would say that, we have an increased burden of cesarean section wound infections and associated complications in our society. So I think that it's very important because of the physical, the psychological, and the costs associated with it that we do address this collectively from a primary, secondary, and tertiary prevention, significant cost to the health service as well. There's many multiple risk factors that can increase the risk of these infections that can lead to the dehiscence, and not all of them are modifiable because some of them are social determinants. So therefore, we need a package to prevent these infections as much as possible. And one way we can do that is looking at the risk factors and the types of dressings, the way we give antibiotics, early identification. And when we do that, think about the normal saline washing, if we're going to use antibiotics and which ones, and then the dressing such as a negative pressure wound therapy to try and do it as well. And then just to refer when you feel is needed, and to just note those red flags about when you need to seek some advice a little bit sooner. So I think that's my last slide here. So I might hand you over to hear about some options that you do have available for negative pressure wound therapy, and we'll come back for question and answers afterwards. Thank you.
Thanks so much, Jared. I'm just going to quickly share my screen. Sorry about that. I hope you can all see my presentation screen right now. So good afternoon. My name is Agata, and I am the Senior Product Manager for Advanced Wound Management portfolio here at Smith & Nephew, and I do look after the PICO single-use negative pressure wound therapy. And today I will walk you through our PICO system and talk to you about what it is, how it works, and what kind of benefits it can bring to your clinical practice. So let's just start quickly with a refresher on what negative pressure wound therapy is. It is an active wound therapy that is designed to promote healing by applying controlled negative pressure to the wound bed or to close incision. It is used in a wide range of wounds, from surgical to chronic. What sets systems like PICO apart is that it delivers this therapy in a revolutionary canister-free single-use format, making it portable, discreet, and easy to use for the patients. So who can benefit from the PICO therapy? Well, there are patients within a certain risk groups that could benefit from negative pressure. And these factors are increased BMI, so over 30, smoking, diabetes, high blood pressure, and certain surgical circumstances like undergoing repeat surgeries, surgeries like C-section, or needing an emergency C-section, for example, or any other kind of surgery. So The PICO system includes 3 types of therapy, and it is designed to be a patient-friendly treatment for a wide range of acute and chronic wounds. The therapy duration is indicated in the product name, so quite easy to understand. For example, PICO 7 provides therapy for 7 days, whilst PICO 14 for 14 days. From a portfolio perspective, PICO offers both prevention of surgical site infections or complications for surgical incisions, and also treatment of acute and chronic wounds such as burns, trauma, or even diabetic foot ulcers or venous leg ulcers, as well as wounds such as surgical dehiscence, which we have been discussing during this webinar. Specifically, PICO 7 is widely applicable ideal for surgical incisions, including obstetrics, for example, C-section, but also PICO 14 is suitable for complex and longer duration wound care needs, including surgical dehiscence. So what makes PICO truly different? Well, it comes down to the system design and the science behind the dressing itself. So let me show you a quick video with an overview of the PICO components.
Discover PICO Single-Use Negative Pressure Wound Therapy System, a patient-friendly treatment for a wide range of acute and chronic wounds. System components include the PICO dressing with innovative airlock technology, soft port tubing with integrated filter, pump and belt clip, extension tubing and fixation strips. This system helps you get closer to zero delay in wound healing. It may promote wound healing via removal of low to moderate levels of exudate and infectious materials when compared to standard of care across a range of surgical specialities, stalled chronic wounds and patient profiles.
So here is an overview of all the PICO components as showcased on this short video. So starting with the pump, it is a small sleek pump with an orange button. It's a single operation for ultimate simplicity. There are also 3 indicator buttons to indicate any air leaks, dressing change indicator, as well as the battery indication. The pump operates on 2 alkaline AA batteries. And it also has a clear belt clip for ease of use for the patients. On the other side, we've got the dressing itself with a unique airlock technology and a soft port. And this soft port may be directly connected to the device, or it can be connected through a longer tubing to allow an option for patients wearing option. It has been designed to reduce the risk of pressure points as well, which may contribute to patient comfort in wear. So let's take a look at the revolutionary pioneering airlock technology dressing, which makes the difference in our PICO technology. And I will present a short overview video for you as well.
The PICO dressing with airlock technology features a 4-layer design that enables simultaneous actions to assist in progression toward healing surgically closed incision sites. The silicone adhesive wound contact layer protects the wound environment by helping to minimize trauma and pain to the peri-wound area upon dressing removal. The innovative airlock technology layer helps distribute negative pressure evenly across the entire surface area of the dressing, to include the incision and peri-incisional area, while still allowing fluid to pass through. Fluid and bacteria pass into the dressing's superabsorbent core. Once bacteria is within the dressing, over 99% is locked within the dressing and away from the wound, as demonstrated in vitro. The 4th layer is an advanced high-moisture vapor transmission film. It has been demonstrated that up to 80% of moisture was evaporated from the dressing, helping to prevent maceration. Also, the film serves as a waterproof bacterial barrier.
So as you can see, all these layers make the PICO dressing not just innovative, but also clinically practical. And they are designed to simplify wound care while driving improved outcomes. So if you are considering PICO for your patients or for your practice, we make it easy to get started. Our partner Team Medical can provide all the detailed ordering information to support you to help integrate PICO into your practice. And also feel free to visit our website via the QR code provided and discover how the single-use negative pressure wound therapy system PICO could enhance your clinical practice and your wound management strategies. So that's all from me. Thank you very much. And I will hand back over my colleagues.
Thank you both for some very a great presentation. Lots of great information there. We'll now jump into Q&A. So we have a couple of questions prepped, but if you want to chuck some questions in the chat as we go along, please go right ahead. We only have a few minutes left. So the first question I have is for Jared. What diagnostic tests are recommended for delayed caesarean section wound healing?
Thank you. Yeah, so I think that, good old clinical vision and thinking about it is number one, to sort of see if you think there is infection. But then number two is to, to rule out an infection, to take a swab just to make sure you're not dealing with something like MRSA. And then the third one would be whether you think that there needs to be a caesarean section, just to see if there's any reason or anything underneath that might be causing a problem. So there's sort of the three things. So clinical, swabs, and then an ultrasound potentially.
Thank you. And what factors should we consider when deciding whether a PICO dressing or a negative pressure dressing is appropriate?
Yeah, so look, I think in these scenarios, there's really good evidence for the BMI, and that's been shown by studies to be a very cost-effective. And so in my hospitals, we have a bit of a flow chart, so a bit of a scoring system. So whether people reach a sort of, a number 3 is what we use. So it might be the time that a cesarean section might be taking, if there's any concerns with diabetes or smoking. So these, if people do come see you in the primary setting, you might say, look, maybe talking to your obstetrician about this type of wound dressing would be quite important. And then if there is an actual dehiscence or infection, the way that I sort of do around that is the machine can remove a certain amount of exudate, but you don't want to be blocking it all up, so you just wait till you've only got a minimum amount of exudate or things coming through, and that the edges are not too far apart that it can come together. So there's sort of the things that when I would use it in a dehiscence or a post infection. So
Awesome. And what are the key indicators of a wound progressing towards infection?
Yeah, so it's sort of, I think, the redness is always hard because it's, that is a healing plate. And we know that it takes 2 years from doing a cesarean section until the remodeling and everything of that area is actually complete. But it's I think number one, mums know best. So it's that sort of a little bit of feeling unwell can be a bit of a sign, but, rule out those mastitis and endometritis. Any opening up of the wound, increase of the exudate or increase of the redness, if by day 5 to 7 things should be turning in the right direction, but if they're not, then that would be a sign that there could be a little bit of infection. It's very hard to think about blood tests and CRP because a cesarean section will put those up, pregnancy will put those up as well. So quite often, once again, taking back to clinical skills, reviewing to see whether you think it's infected, which primary health people do much better than I do. So
Thanks, Sharon. And if a PICO is placed directly on a C-section is complete, and our PICO dressings waterproof?
So you can definitely put them over the cesarean section wound. We do them at the time of cesarean section when we're trying to use it for prevention. And my scrub nurses are even better than I am because they are experts because trying to make sure you get a really good vacuum. And then waterproof. They do sort of allow a little bit of evaporation to come through. They're designed in that way, impermeable, but they're mostly impermeable. So they are. You can definitely. I'm going to actually ask the expert about whether, I don't know if you can immerse them in water, but
Oh, thank you. Yes, it's all correct. The dressing is waterproof. However, we don't recommend submerging it in water. And especially important information, it is to disconnect the pump before entering the shower and then reconnect the system after the shower. But the dressing itself, yes, it is waterproof.
Awesome. I think we have time for one more question before we wrap up. And So, Joe, what type of dressing do you typically use on patients if they don't qualify for the risk factors where you would choose to use a PICO?
I think if you go to an obstetric conference, it's always one of the highly debated sort of things. So quite often people do use everything from sort of your fix-and-mold based ones to your honeycomb. And I think there's one that absorbs anything. And there is a bit of a difference between if you do have some complications, such a little bit of ooze, if it's been an emergency cesarean section, compared to a more elective or anything together. So look, I don't think there's a right or wrong answer there, but just to sort of look at the situation, and if it is a little bit of exudate, make sure it's something that absorbs that, because we really don't want that sitting on the wound, and that can cause breakdown. And it is sort of amazing that, good old Mother Nature by 48 hours is pretty impressive, that, things are naturally sealed over by the scab, and sometimes keeping it open if there are no signs of anything going wrong could be quite a good option at that time period as well. But the first 48 hours, the majority of patients, it's best to have one of those absorbent dressings on.
Great. Thank you. We'll wrap up the questions now. Thank you, everyone, for joining. Jana will now post a link into the chat. If you could please complete a survey and give us your feedback. Thank you so much again for presenting. And we hope that everybody found this very valuable. Thank you.
Thank you.
Thank you very much.